things like corticosteroids. You're going to use things like interferon, things like that to treat them. Okay. No distinctive signs and symptoms. A lot of times they come in, they look like strokes, to tell you the honest truth. But young woman or man complains more than one episode of dysfunction. You cannot diagnose them with multiple sclerosis just with one lesion. And we're not going to go into details of the test, but usually they have to have more than one lesion, or if they have more than one lesion or more than one occasion. So it's if they're coming for the first time and they're having these symptoms and you suspect MS, they only have one lesion, you cannot diagnose this. If they have more than one lesion in different places, you can possibly diagnose it. If they come in on two separate occasions, one lesion where they have optic neuritis on this one, and now they have numbness in one side in their arm, so they have the two lesions in two separate places, then you can possibly diagnose them with MS if they have the other factors. This is what we call McDonald's criteria. Requirement for dissemination in space and time. Must have 2 clinical attacks or 1 clinical attack, but MRI evidence of more than 1 attacks in different locations, clinically and radiographically. And this is what we just talked about. Myasthenia gravis. This is a disease or a neurological condition where you don't have acetylcholine at the neuromuscular junction. Acetylcholine at the neuromuscular junction is what innervates our muscles to move. And we have in people with myasthenia gravis, you have an autoimmune process that breaks down acetylcholine at the neuromuscular junction. And this causes muscle weakness, okay? Usually they present with what we call ptosis, where their pupils, their eyes close and they're not able to open it. The distinguishing factor with myasthenia gravis is with rest, they usually do well. So they'll wake up in the morning, their eyes are wide open, and by the end of the day, they're walking or they're doing whatever, and now by the end of the day or before the end of the day, their eyes close down, their arms are weak, their legs are weak. It can actually paralyze your respiratory muscles, and that's a medical emergency. How do you treat these patients with autoimmune IVIG? You give them something that will stop the breakdown of acetylcholine at the neuromuscular junction. So you want to give them the meds that will actually stop the breakdown. You give them pyridostigmine or mestinon. Those are the things that you're going to do. They have found that people who have their thymus gland, as we grow, when we're born we have a thymus gland, but as we grow our thymus gland shrinks. They have found that people whose thymus gland does not shrink have a higher risk for myasthenia gravis. So usually when someone's newly diagnosed, they'll do a CT of the chest, look for the thymus. If the thymus is there and there's some hyperplasia, they'll remove it, and usually the patients go into remission. So that's something they definitely have to do. This is a ptosis, and this is the first, usually the first sign of myasthenia gravis that you're going to see. Guillain-Barré, acute mediated polyneuropathy. This usually is provoked by some kind of respiratory infection or a gastrointestinal infection, and the immune system starts attacking itself. Usually what happens is they have ascending paralysis, okay? So it starts from the legs, come up, and they start getting progressively weak in different parts of their body. This morning they could walk to work, tomorrow morning they can't move their legs, and it comes to their arms, and then goes to the diaphragmatic muscles, which can actually cause respiratory collapse and death. It's progressive, it's symmetrical, and it usually is an ascending paralysis. Okay, and there are subsets of Guillain-Barré that, or variants, I should say, of Guillain-Barré that can start with the arms or the eyes, but generally it does start as an ascending paralysis. Okay, and this tells you here. Okay, treatment, usually, again, this is self-limiting. This is not a disease that they have forever, even though some are prolonged and some stay longer than others. There's some people within months they're better, some people years they're better, some people weeks they're better, so it varies tremendously. Okay. IVIG they can give, they're giving immunoglobulin, they're giving steroids, things like that to treat Guillain-Barré. Okay. Oculomotor weakness, severe respiratory muscle weakness, facial and oropharyngeal muscle weakness. So aspiration risk, oropharyngeal muscle weakness, facial muscle weakness, aspiration risk, paresthesias, pain, respiratory muscle weakness, that's respiratory depression. So it can be very debilitating for the patient. They can have things like dysautonomias where the autonomic nervous system is going out of whack, so they have tachycardia, urinary retention, hypertension, alternating with, so they have the sympathetic nervous system going crazy, then the parasympathetic nervous system going crazy, so they can have these dysautonomias associated with it. Okay, how do you diagnose these patients? Usually they'll do a lumbar puncture, and on the lumbar puncture there will be no white blood cells, but there will be elevated, significantly elevated protein. And this is taken into context because you have the ascending paralysis, and then you have a lumbar puncture with CSF with elevated protein and no white blood cells. Then this is likely Guillain-Barré. Amyotrophic lateral sclerosis, ALS. This is an unyielding, progressive, incurable neurodegenerative disease process. It's a diagnosis of exclusion. There's no particular race or creed or color that's implicated by this. There's no treatment. Usually people end up dying from respiratory complications. And it can be very fast, it can be very insidious onset, or it can be people last for a while, but it usually, again, they've worked everything up, they look for everything else, and then this is basically what's left. Again, diagnosis of exclusion, they can do electromyography, where they look at the nerve conduction, velocities, and stuff like that. Okay. Weakness, hyperreflexia, spasticity, they can have upper motor neuron findings and lower motor neuron findings. Remember, spasticity, rigidity, that's upper motor neuron, flaccidity, paralysis, lower motor neuron. All right, we're almost done. We're on seizures. Let me just check the time. All right. I have a few more minutes. So seizures, status epilepticus. Seizures, this is basically a disorganized activity in the brain. You have different types of seizures and things that can cause seizures. They can have tumors that can cause seizures. Anything that irritates the brain can cause seizures, okay? Membrane defect leading to instability of resting potential, action potential. So you just have the action potential firing. And this causes increased consumption of cerebral oxygenation because the action potential is consistently firing. And this is where you have a seizure. Okay, they don't have GABA inhibition. We said GABA is a neurotransmitter. It's a inductive neurotransmitter. So it's a neurotransmitter that kind of calms the brain down. So these people can have defect and they inhibit GABA. Or they have not enough GABA. And then they have these action potentials that are firing. Different types of seizures, epileptic versus non-epileptic. Idiopathic seizures, we don't know why. Then you can have secondary due to some kind of a lesion on the brain. And then you have non-epileptic, febrile seizures, metabolic disturbances, head trauma, encephalitis, poison and toxicity, all can give you these. Your secondary epilepsy can be stroke-induced, tumor-induced, all those. Now you have partial seizures versus generalized seizures. Partial seizures usually means that it's part of the brain that's being affected. You have simple partial versus complex partial, and then you have generalized absence, tonic-clonic, myoclonic, and atonic. Your simple partial seizures, they're usually awake. They'll have twitching of the arm, and they can see that their arm is twitching and is uncontrollable, but they're awake and they know it's happening. Your complex partial seizures, they are awake, but they're not aware. So usually these patients are at high risk of hurting themselves because their eyes are open and they look like they're looking at you, but they're looking through you. They don't know what's going on, okay? Your generalized seizures, that means the entire brain is involved, and usually they can have tonic-clonic, absence seizures, and they're just completely zoned out, they're completely gone. Okay. Simple partial, they're focal seizures, no alterations in mental status. Complex partial, psychomotor, associated with impaired consciousness and some automatic behaviors. They can have automatism where they're doing lip smacking, they can do just repetitive movements. Okay, they may evolve to a generalized seizure. They can start as partial and then evolve to generalized seizures. Okay, complex partial seizures begins with focal and then it can spread to different parts of the brain. Again, patients staring off, they look like they're looking at you, but they're not, they're looking through you. Patients can hurt themselves because they can walk, they can fall downstairs, they can actually be doing stuff while this is happening, but they're not aware that it's happening. Okay? Complex partial seizures, impaired consciousness, the blank stare, vacant expressions, superior temporal gyrus, you can see that. They can have different smells, they can